Good afternoon. I'm David Blumenthal. I am a professor of practice of public health and health policy at the Harvard T.H. Chan School of Public Health. And it's my privilege to have Eric Hargan joining us today. Eric was Deputy Secretary of the Department of Health and Human Services in the first Trump administration. And he is currently a resident fellow at the Institute of Politics at the Harvard Kennedy School of Government. Thank you so much for joining us, Eric.
Great to be here.
One of the reasons I'm so delighted to have this opportunity to talk with Eric is because I've spent some time learning about the work that he participated in the first Trump administration. A book that I've written with a co-author that will be out early in 2026 looks at the topic in depth of what Eric actually made happen or participated in making happen, and that's Operation Warp Speed. Operation Warp Speed, for those of you who don't remember or aren't familiar with it, created the COVID vaccines. And just for perspective, that vaccine saved over 1 million lives and several $1 trillion worth of medical expenditures. 150 or 200 years from now, this will be remembered, this Operation Warp Speed effort will be remembered as the first time in the history of the human race that we encountered a deadly new infection and within 12 months identified it, understood its genomics, produced a 95% effective vaccine against it, and rendered it a now common threat to which we are all adapted and for which few of us have deep fears. This was an historic event in human history. COVID-19 killed, as of April of 2024, had killed about 1.2 million Americans. In all of our nation's wars combined, since the founding of our country, we lost 1.3 million Americans. So a couple of years, 1.1 million, 250 years, 1.3 million. And Operation Warp Speed effectively put an end to that catastrophe. So we're really delighted to have Eric here because he was central to this story. Could you tell us first how you first became aware of Operation Warp Speed and how you were drawn into it?
Yeah. So, and thank you, David. I would say that Operation Warp Speed really an inflection point in my career. You know, probably I'll never be associated with anything like it in the future. I hope not. For everyone's sake, right? With the crisis that brought forth. So it didn't start as Operation Warp Speed. So it started out as MP2. Was where we started hearing about it, we started talking about it. It was Manhattan Project for Health, or Manhattan Project 2, and then MP2. In first part of this was when this started taking off, started conceptualizing how to bring a vaccine swiftly to put an end to this as one of the only ways that we knew we could move against the disease that had started so strongly and was devastating, right? And in sort of the first half of April, a memo came out, Operation Warp Speed. So that was how we had a couple of people, Dr. Cadlick and Dr. Marks, authored the memo. And so that started going around. And then that was the point when that happened that it became Warp Speed. And we started really kind of instantiating the operation inside the department. Got that memo, and that would be sort of when I joined Operation Warp Speed, right? Sort of when that came out and when it became Warp Speed by name. At that point, you know, it had a lot of things about what we were going to do, and many of them because as Deputy Secretary, you're sort of the Chief Operating Officer of the department. That's sort of your role in there, sort of the number 2 and the COO. So I was turning to the operational side of Warp Speed. Here's an organizational chart in the memo. Here's who's going to be doing it. I start calling the people involved and saying, so warp speed. And some cases people were like, what's that? And so, kind of the person to introduce them to what was going to be happening from an operational point of view. I'm not a clinician, but I'm a lawyer by way of training and was acting as a COO. So that was sort of the role that I helped play.
Yep. Now, what was it that enabled Operation Warp Speed to move so rapidly? I mean, the term warp speed, by the way, as I understand it, grew out of the interest of Peter Marks in Star Trek.
Yeah.
So he developed the idea. It could have been called Manhattan Project 2, but it wasn't quite as catchy as Operation Warp Speed.
Right.
But one of the things it did have was speed, or that was the intent.
Yes.
So how was the big bureaucracy of HHS capable of turning on a dime the way it did?
Yeah. Well, there were a number of things that we did, and from a detailed point of view, but really a lot of it had to do with the amount of autonomy that we had within the department to manage this thing. In government, a lot of times, as everyone knows, government is not legendary for moving very quickly. But this was a governmental project at the largest department. So you manage, the idea that we could move so quickly wouldn't necessarily be expected in something like this. But we were given a great deal of autonomy. Usually in government, when there are projects going forward, particularly those that are perceived to be successful, a lot of people decide to contribute, right? They want to know what's going on. They want check-ins, they want data, they have good ideas, they want those reflected in it. A lot of that didn't happen. A lot of those, there was no accretion of a lot of people. Really, a lot of the team that started is the team that actually carried it out in Warp Speed. And so you didn't have this kind of rolling group of people that just kept adding on and adding on and adding on. So in many ways, we were kind of insulated from what had happened and what usually happens in government. So this was a very unusual project in that way. There were a lot of particularities, things that we did with in terms of contracting, being able to sort of contract ahead of time. We took a lot of different principles. And I'm going to speak about this only from like a budget and operational point of view, because that's my perspective on this. I'm not a clinician, didn't do research, didn't do any manufacturing, didn't distribute the vaccine. So, but the role in terms of being able to kind of look ahead, do milestones, promise that we would pay for the vaccine when it was developed, really have the money ahead of time that we could commit to these things, all helped the companies that were doing the vaccine be able to know that we would pay for it and that they could be comfortable developing the vaccine, manufacturing it, distributing it, knowing that it wasn't an item of just conjecture. In fact, we were there, we were going to back it up, and we would help participate in it. We made NIH clinical sites available to everyone to use, so they didn't have to do a lot of those things. There were a lot of steps that we took in terms of being able to do that. We vetted the companies, which ones could do it. We had a mesh of which ones could do it, and pulled that together very quickly.
So just because my research on the book looked at this from the White House perspective,
right?
One of the things that made it possible for you to be so successful was that this was the president's project.
Yeah.
And so he basically made it clear that nothing should get in the way. And that's one of the reasons why you were left alone.
Yeah. And what's interesting is that, as we talked about it in the past, like that's something that wasn't always available, like to somebody like me in the team down in the trenches,
Sure.
was just because I was not going to question it, right? I didn't question it, the fact that we were unusually insulated from a lot of the normal things that happen in projects like this,
Yeah.
but it was entirely welcome and I think necessary.
And there's a lesson for how presidents make things happen in a technological field like this, which
Right.
is, and by the way, which didn't happen with respect to Obamacare's website,
Right.
which failed
Right.
for lack of presidential attention. It's a very interesting story from that perspective. So public-private partnerships
Yeah.
were critical to this.
Yeah, absolutely.
And talk a little bit about how that evolved and how the Secretary Azar,
Yep.
and you were able to make those partnerships work.
Yeah. Some of it comes from familiarity. Obviously, Secretary Azar, CEO at Eli Lilly, so he already knew the pharmaceutical world very, very well. And so the ability both to conceptualize it at the very beginning, to be able to animate the people that would be necessary to do it, to bring them in on that, like Dr. Sloughy, who was sort of heading up the vaccine side of Operation Warp Speed. There's a therapeutic side as well, but that's not as well known. But be able to bring these kind of people to the forefront, to be able to do that. Those were important abilities to conceptualize and to carry it out, to know what the steps were. So internally, we had people who already knew what this process would be. My background was as sort of partner in sort of big law firms, right? And so the work, and as a COO, it fit pretty naturally for me to work on the sides of it that dealt with the budget, the operations, the contracting for what was going on there with the budget and the legal teams and the operational people. So that was, but it was sort of, that was, I think, hopefully helpful as well, was in fact sort of decades practicing law in there helps with that side. Not with the clinical side, or in many cases the operational side, that sort of corporate side of things that the secretary brought to this.
Sure. There was something else, what seems like a tiny detail in the usual perception of government operations, but I think was very important, and that was the Defense Department.
Yes.
So talk a little bit about the Defense Department's role in this.
Yeah, so General Perna was brought in early because we had sort of, HHS can feel comfortable at sort of the clinical side and evaluating those kind of things, right? And can, FDA is internal to HHS, so how's manufacturing done, right? But what are you going to do about the logistics of carrying these things out? Who can do that? Well, we ended up inviting the Defense Department into this. Now that's an unusual thing inside the Humphrey building, which is the headquarters of HHS, is to see fatigues and military uniforms wandering around inside the Humphrey department. You're much more used to sort of doctors, scientists, even economists at the Medicaid side of things, but you don't usually see them. But it was, again, that was a crucial decision because they understood very well how to carry this out. And could plan the logistics out. Now, we didn't end up relying actually on like the Army to hand out the vaccines themselves. The private sector did that, medical sector, UPS and so on, McKesson. And so we relied on the private sector, again, public-private partnership for underlying what we did there. Again, just like turning to the pharmaceutical companies for this, turning to those for that, but to have inside the government the ability to carry out those logistics by the people that really knew how to do it was crucial to that, absolutely crucial.
So General Perna was the head of the material command for the U.S. Army. So when the Army goes abroad, all the tanks, all the artillery, all the food, it was General Perna who made that happen. So there was no better logistician in the federal government than General Perna.
Yeah.
And by the way, just as a historical parallel, the real Manhattan Project, the original one, created the atomic bomb also in record time, combined a scientist with a logistician. The logistician had been actually the gentleman who worked for the Army and built the Pentagon, and the scientist was Robert Oppenheimer. So there's an interesting parallel here, part of the success. One other thing I'd like to just spend a moment on, because it's such a nerdy thing that you would never think it mattered, and that's contracting.
Yeah.
Talk a little bit about contracting.
Sure. So that was an element here that was not always appreciated, right? I think was that contracting, the ability to kind of promise ahead of time that you're going to be able to do this, to establish milestones, to be able to garner the money necessary to do the thing is very important. And we didn't have a warp speed bill that handed the money out. So we had to actually find pots of money inside the department and sort of purpose them towards warp speed. And so we had teams of lawyers and budget people looking those over to find out how we could find that money without kind of spending a lot of time in front of Congress to do it, and make sure that it was all tightly done by the rules on that. And so we had to do that in certain order, because also we had to make sure that some of those, when you repurpose money, you notify Congress within a certain period of time about it. And we were moving very quickly, and in many cases very quietly, to do these things, because if we're going to be buying a lot of products. In other words, we've got 6 vaccine candidates. We have to plan for each one of those to be the successful candidate. So we're buying 300 million plus doses potentially of these vaccines, each of which has their own particular needs for manufacturing them. So we had to get out there, and if anyone knew there's an emergency and the United States government is out there in an emergency trying to buy things, guess what happens to the price? Like this. So we're trying to move quickly and carefully to get these contracts under there. I had the interesting thing of signing the first one of those documents, launching it from my perch. We had to do a lot of those things. Actually, they let me keep the live copy. The lawyers let me keep the live copy, which is a treasured thing for me. Actually, was that the document that sort of officially launched it. Although it was, obviously we were already doing it, but we had to get those things done. But because we were able to use a lot of different contracting principles that had rarely been done together. In other words, it wasn't that we hadn't done them before, but doing them together was what allowed us to kind of sort of create a much more streamlined process for acquiring them and being able to get the companies confident that they could dedicate the amount of resources that they needed to internally to get these products done as quickly as possible.
There was one other part of the contracting, and that has to do with who was doing it. It was the Defense Department to a large degree. So I've worked in HHS. I've supervised contracting in HHS. It's a nightmare. It's a total nightmare. It takes forever, and you have very little control over who gets the contract. The Defense Department has much more flexibility. They can do sole source contracts. After all, they defend the country. They have to react to emergencies. They can't wait a year and a half to let a contract. Say something about the Defense Department role.
Because they have this, HHS has very few of these things. It's called Other Transactions Authority, things like that are special contracting authorities, OTA and different things like that. So we have some avenues for it, but it's not robust the way the Defense Department is. So while we have a certain amount of sort of budgetary authority, HHS is sort of the behemoth inside the government from a budgetary point of view, the ability to kind of creatively contract for these things at each one of them in turn, it's easier for them to do it, right? And they also know where things need to be because they're handling the logistics of this, so on the ground with the companies that are actually going to do it. So they're building that out, which is why it was able to be done so quickly. I mean, we ended up, I think it was the first week of January was the first day we had 1 million vaccinations in a 24-hour period. And that was 3 weeks after it was approved in mid-December. And that's counting sort of Christmas and New Year's in between. That's how quickly it was able to be spun up in terms of administering the vaccine. And that was in many cases to the populations that were most crucially affected by it, the ones that really, really had to get those doses early on. And in December and January, obviously, height of respiratory illness traditionally.
So just to make clear what the time frame is here and how miraculous this was, it was in May of 2020 that President Trump went to the Rose Garden and with Tony Fauci and I forget somebody else at his side, maybe Francis Collins, announced Operation Warp Speed. January of 2021, the first doses of the vaccine are administered.
Even in December, we had some administered and clinical trials. So they were being administered in the clinical trials earlier. But yes, you're right.
That's 8 months.
Yes.
from the announcement to the availability of the vaccine.
Right.
That is extraordinary.
Yeah.
Never been done in human history before.
No.
And so to do all the things that need to be done to get that to happen
Yeah.
was really an extraordinary feat of governmental and private sector collaboration and action.
Yeah, it was, and it was interesting because for that level of collaboration, that was I think a testament, really across the whole spectrum of the people who were there. Because traditionally, government and the private sector often are at loggerheads with each other, but you sort of saw the scales fall from people's eyes, right? Gradually, they were sharing with each other. They were working collaboratively in a way that you rarely see, maybe never.
Yeah.
And it was an emergency, right? But it does give you, I think for me, it gave me a great encouragement about the ability of our system, that it has enough plasticity, enough ability to react to these things, that we could turn and change our attitudes and behaviors very quickly under pressure without breaking. And I think that should give everybody a lot of encouragement for kind of the inherent resourcefuless
And
of
legally.
our system. Yeah, yes, absolutely.
And
And legal. I appreciate that. Thank you.
Okay, let's change the focus a little bit, because a lot of other things happened on your watch that were special to that period. And one of them was the birth, not the total birth, but say the maturing of telehealth.
Yep.
Tell us a little bit about the telehealth story. And I know
Yeah.
I learned from this material that you're from a rural
Yeah.
background.
Yep.
Didn't know that
Yes.
up to now.
Yeah.
Where are you from?
I grew up on a farm in deep southern Illinois,
Okay.
right near the southern tip of the state. So, and I grew up in a family that for 5 generations back in healthcare, back to Doc Hargan in my little county, Pulaski
Great.
County, Illinois, the late 1800s. So grew up really in that kind of background, but in a rural background. And we had been working for a couple of years on what we call the Rural Health Action Plan, sort of trying to revamp and revitalize the area of rural health. That had been going on for a while. We had been animating sort of all of our agencies, come up with ideas for how to solve what's a very difficult problem, sort of remote and rural care. Well, we had been doing a lot of policy work on that, and so sort of thinking through the problems, things like telehealth, right, obviously as a solution, which had been very constrained in many ways because it was constrained legally where it could be used, which itself kind of made the market fairly small and meant that a lot of things just kinks hadn't been worked out in that. So early in the pandemic, started thinking through the role of telehealth because people were really scared of going to the hospitals. They were scared of going out of doors. Governments were kind of starting to go discourage that, prohibit. There was a lot of things going on already at that time. And a lot of them because the public itself was worried about what was going on at the beginning of the pandemic, which they continue to be. So we had already seen that the hospitals, people weren't going there, people weren't going to the doctor's offices, sometimes they weren't open anymore. So telehealth was kind of an obvious thing to do, but there's a lot of regulatory impediments in that. We had 3 different agencies that had to change their rules to allow it to be opened up, and we were able to do it relatively early in the pandemic, but that wasn't entirely because we were able to move so quickly, and in a moment of genius, it was really because we'd spent a couple of years thinking through the policy implications and thinking about it. And so we were able to kind of move much more quickly at that time because we had molded over in the way that government has to, right? In that way, as you well know. These things take time. You've got to consider things from a bunch of different angles, but a lot of that work had been done. And so we were able to kind of move very quickly with all those 3 agencies coordinating very early in the pandemic, and it just took off like a rocket. I mean, lots of things including things that were done, I think, many ways much better afterwards. Like you see things like adherence to mental health check-ins done much more easily and quickly. A lot of things were really turned around and it became, I think, a permanent part of the American medical landscape after that. And a lot more sophistication, people building out how they would do it, places that it could be used. So that is you don't ever want something like that to happen, but it was a distinct silver lining from the pandemic, I think, and it's kind of a permanent element and a positive one, I think.
And one of the critical things, I'm a clinician by background, and so I'm very sensitive to payment. One of the critical things was getting the Center for Medicare and Medicaid Services to pay for this.
Yeah.
You want to say something about that?
Yeah, that was very central, was kind of making the payments more equal, because telehealth, naturally people were saying, well, it should be down here, you're not having the time, and all the things that had to be fixed, right, in a way, because we had to be able to access those services in a way, and it simply wouldn't have happened. And also, we had a technological limit that had been imposed by HIPAA. So we had the Office for Civil Rights, which oversees HIPAA, had to kind of work flexibly to decide it wasn't going to just allow these sort of encrypted programs that had been, set for the telehealth programs, but was going to allow things like Zoom. Didn't allow all of the software, because they had to look at it from a security point of view to make sure it couldn't easily be, people couldn't just drop into consultations from outside, and places that couldn't be hacked as easily, so people could actually have private conversations with their providers. But it still meant that they would allow more ability for those platforms to be used, which is what is being used to this day. So it's both the combination of a change in the regulatory landscape from the HIPAA and technology point of view, and then, of course, the financial side of things. So CMS could lean into it on one side, and the people regulating under HIPAA leaned into it on the other, so that you could do both of those things at the same time, right? Which, it's like, getting agencies to coordinate to come out at the same time. That's elephants dancing together. No offense to the agencies, but that was some doing, because they all had to kind of do it all at the same time to get it to go at the same time.
Sure. So we're coming to the end of the live stream, but I want to, because this is a school of public health, and we train people to be public servants here. You've been spending time at the Kennedy School, which trains people to be public servants. One of the things that stands out about this story, both on the telehealth side but on the Operation Warp Speed side, was the importance of competence in government. So we were fortunate to have Alex Azar as secretary. He had deep knowledge of the pharmaceutical industry and management expertise. And he knew where to go to looking for scientific help to run this. He helped choose Moncef Slaoui as the scientific head. You had a lawyer trained in contracting and in private sector work as his deputy. And then you had people throughout HHS who knew how to pay for things at CMS, knew how to provide the regulatory assistance. So competence at every level made it possible, plus presidential support, made it possible for this to execute effectively and legally. So just there's a purpose to the training that people at the School of Public Health and the Kennedy School are getting, even though we sometimes lose track of what it takes to make government work well and to keep American people safe. Great. Well, thank you for all of you who've joined us on the live stream. And I think we've reached the end of that portion of the program. So we will hang around here a little bit, those who are here in person. But for the rest of you, if you're interested in this, you can find it posted on the Harvard T.H. Chan School YouTube page. And have a great afternoon.